I'm now in conversation with Dr. Prasanna Sooriakumaran, who is based in London. He has a clinic in Harley Street, and his organisation is called Santis Health. He is a urologist by profession, and I'm going to talk to him now about his career, about his company, the work that he does, the developments that he's seen during his career. And we're going to conclude by having a quick preview of the points he's going to cover during his talk surgery masterclass, which is scheduled for the beginning of October. So if you don't mind, I shall refer to you as Dr. PS to avoid any pronunciation complications. So Dr. PS, would you just say a few words about yourself, what you do, and Santis Health?
Sure. Thank you so much, David. So my name is Mr. Sooriakumaran, Prasanna Sooriakumaran, but as you rightly said, a lot of people call me by my initials, PS. I'm a urologist, as you said. I trained in Nottingham in the UK at medical school, and then came down to London shortly after that, did my basic surgical and high surgical training in London, did a PhD in prostate cancer in Guildford in Surrey, and then moved to New York at Cornell University, as well as at the Karolinska Institute in Stockholm for my fellowship training in robotic prostatectomy surgery. I then got appointed as a consultant academic urologist at the University of Oxford by the Nuffield Department of Surgery head of department. And so I went to Oxford and became a consultant there with an academic and clinical practice for 3 years. And then I moved down to London, to University College London Hospitals on the NHS. And then I, shortly after that, also started doing some private practice work in London. But of course, I still have an NHS commitment as well. The private practice commitment I have is through a clinic that I set up along with a colleague called Professor Christopher Eden, and the two of us run Santis Health together. The reason we set it up was because there's a lot of prostate cancer surgeons out there, but one of the things that isn't well done is outcome assessment for patients. So it is quite difficult actually to try and figure out what outcomes different surgeons have. And so we wanted to be very transparent when we started our private practice in London in allowing patients to be easily able to access what our outcomes were. And for that, we wanted to record patient reported outcomes rather than just surgeon reported outcomes, because that's been shown to be far more robust, really, in actually providing a realistic picture as to what patients can expect after surgery. So we set up a clinic together where all patients that come through that clinic have their outcomes measured prospectively, i.e. in real time, and it's outcomes that are relevant to them rather than outcomes that the doctor thinks is relevant. So it includes quality of life as well as erectile function recovery as well as continence recovery. And then we monitor those outcomes throughout their journey with time. And then we can collate them with other patients and stratify them based on age or, weight or whatever criteria it happens to be, such that when patients come to our clinic, they can type in their individual parameters and find out what their tailored outcomes are most likely to be. And so we set that clinic up sort of July 2017 now, so 3 years ago, almost to the day, and it's become pretty successful, and we operate out of a few private hospitals in central London, the Princess Grace Hospital, London Bridge Hospital, the London Clinic, and as you said, the Harley Street Clinic as well. So that's a little bit about me and my current practice.
That's excellent. I'd like also, just from a human perspective, to tell me how you got into the medical profession in the first place. What was it that led you to become a surgeon?
Yeah, so I think it's difficult to know whether it was free will or whether it's imposed by your parents, isn't it? Because my dad is a doctor, most of my relatives are doctors in terms of uncles, aunts, etc. So I come from quite a medical family, both in the UK and in the US and other parts of the world as well. So it was kind of It was kind of something I was very well exposed to, but I was, always very keen on using my hands and science. And of course, like many people, I have family who've had cancer, throughout my childhood, and that of course exposes you to that as well. And you kind of want to do something that allows you to use your hands, but also your brain, and also helps people. And actually, being a surgeon kind of ticks all of those boxes.
You've got a family background in the medical profession. What was it that actually persuaded you to go into urology, or was that just an accident?
Yeah, no, I mean, it wasn't something I wanted to do or thought about doing until pretty much I finished as a doctor. When I finished as a doctor, my first job as an intern house officer was with a urologist in Nottingham, and he was a lovely man. And as with all these things, you get influenced by the people you respect and you like and admire. And I really enjoyed working for him. And the other thing about urology is it has a nice mix of both surgery but also medicine. You get to do quite a bit of both. The other thing is it's a surgical specialty which has a lot of minimally invasive surgery. So even back in those days, before the robot came to being, we used to do quite a lot of endoscopic work, doing cystoscopies and biopsies and things. So it's quite a lot of that kind of work, endoscopic, laparoscopic work, keyhole work, rather than having kind of big cuts and things. So I always quite enjoyed that. I was always quite good at hand-eye coordination and things. So I quite enjoyed the kind of, computer game aspect of using your hands here and something happening over there kind of thing. So to me, I enjoyed the surgery. 1 in 4 cancers are urological. So if someone that wanted to get into cancer surgery, urology cancer surgery is a good thing because there's so much of it out there. As you know, the commonest cancer in men in the West is prostate cancer. 1 man dies every 45 minutes in the UK from prostate cancer. So there's plenty of scope to try and improve things with prostate cancer. And there's plenty of patients out there. So to me, urology and prostate cancer kind of fitted together and played to the kind of hand-eye coordination skills I wanted to do, plus also the kind of variety between medicine and surgery.
You mentioned robotic surgery earlier on. Perhaps you could just say a few words about some of the changes in technology in your line of work during your career, and maybe also give us some thought and insight into the future of robotic surgery.
Yes, I mean, I graduated medical school just 20 years ago, 1999, so 21 years ago. So when we graduated medical school and we started doing urology, radical prostatectomy, which is the surgical operation for prostate cancer, was all done open. And a few people were starting to do it, think about doing it with the chopsticks, pure laparoscopic surgery. And then over that sort of 20-year period, and especially over the last 10 years in the UK, people have moved, completely to robotic surgery. So that is where we have a large robotic device where we're not sitting at the patient's side. We are looking down a console in 3 dimensions. And when we move our hands in hyperspace, robotic instruments inside the patient move, but filter out our tremor, and we get ×10 magnification in terms of vision. So it's hugely improved outcomes for patients, massive, massive improvement, and it's completely changed the field. So as I said, so many thousands of prostate cancer surgeries happening every year. And now in the US, something like 90% are done robotically, and in the UK, it's something like 85%. So it's a huge sea change from having open surgery to now having everything done robotic. So that's made a massive change, not just for prostate cancer, which is my specific area of expertise, but also for other cancers, bladder cancer as well, robotic surgeries come in, kidney cancer, robotic surgeries come in, gynecology, the commonest robotic operation now done worldwide is robotic hysterectomy. So in gynecology, the robot has become hugely advantageous and therefore prolific. And even head and neck cancers, colorectal cancers, and even some benign diseases as well, such as PJ obstruction in terms of my field of urology and many others. So robotic surgery is here to stay. It's completely revolutionized the entire field of surgery, but especially urology and especially prostate cancer for me specifically.
That's very interesting. A few years ago, at a conference in Kuala Lumpur, when I was speaking, they had an exhibition alongside, and they had if you like, a serious games tool based on laparoscopic surgery. So you had haptic feedback, and you used the chopsticks, as you described them, to remove a gallstone. And one of the things that interested me was the fact that my partner had a go at this device. So she was watching on the screen what she was doing. And the way that this was structured was that you were measured in terms of the accuracy of your and the skill with which you operated the devices, and also the speed with which you were able to perform the operation. And according to the people who are manning the stand, my partner, who has absolutely no interest in computers or video games, proved to be better than some trainee surgeons. So it led to me to reflect on the fact is, if you're going to go into, forgetting about robotic surgery for a moment, if you're going to go into surgery, are you better to be operated on by somebody who's very skilled with the tools like you might do in a video game, or what's the balance between those kind of skills and actual clinical knowledge? Is it less demanding these days? If you're just talking about laparoscopic surgery, is it less demanding on surgeons than it used to be with the tools that you've got available today?
Yeah, I mean, I think the way I would, analogize it is a bit like, playing a sport. Let's take golf, for example. You can give, Tiger Woods a wooden club and he'll still hit the driver shot better than me, right? You can give me the best club in the world, it still won't be as good as Tiger Woods with a wood, but you get it with a wooden club. But if you give Tiger Woods the best driver in the world, he'll hit it even better. So you need both. You need the best kit, but you also need people that are well trained and are experts in using that kit. So it's not an either or. So your partner, for example, may have had, showed some natural aptitude of having the kinds of skills of hand-eye coordination or whatever, judgment, decision-making, immediacy of decision-making to make her, to have the potential to be a good surgeon, but that doesn't mean she's a good surgeon. It just means that she could potentially grow into that. And equally, my 6-year-old child, when they started playing golf, may have hit it all over the place and hardly hit the ball, but now he's pretty decent at playing. So it's, playing golf. So a lot of this can be taught by repetition and by muscle memory. So it's a combination really of the two. What you ideally want is in terms of surgery, whether that's laparoscopic surgery or robotic surgery or even open surgeries, you want surgeons that understand the disease well, are invested in the disease, because it's not purely technical, it's also about knowing when to operate, how to operate, etc. So understand the disease, understand the anatomy, are invested in the patient aspects of things, the holistic management of things, but also technically have done the procedure so many times that it becomes reflexional to them. So they're not like a learner driver that has to think where the left foot goes, where the right foot goes, where their hands are at 10 and 2. It just comes instinctively. They don't have to think. It's just automated behavior with muscle memory. And then, because they've done it so many times and they've been well trained by, in my case, the best surgeons in the world. I mean, I trained in New York at Cornell with the surgeon that was involved in the very first robotic prostatectomy case back in 2000 in the United States. And then I went to the Karolinska and trained with a surgeon in Europe that was involved with the very first robotic prostatectomy case in Europe. So I trained with people that at the time had done many, many thousands of cases between them when I had learned, so I could have learned from their mistakes rather than having to make my own mistakes, because I've learned from what they have already done. So you get the best trainers and then you do the operation over and over and over again. So similar, as I say, to that golf analogy, I can take a golf club and have no lessons and spend hours and hours on the golf course and I'd still be no good. Or I can pay for the best golf professionals to train me and spend an hour a month on the golf course and still be no good. But if I get the best guys to train me and then I spend 10 hours a week on the golf course, I'll probably be pretty good.
Yeah.
So the same thing with surgery. If you have people that you get the best training and then you put it into practice over and over and over again, that's what produces the best patient outcomes.
I think that's a very good analogy. You mentioned you had some training in the USA, in New York. Can you make some sort of comparison between the health systems and outcomes in the USA compared to the UK? I know your experience is a few years ago now, but have you got a view on?
Yeah, well, I'm still in touch. I still go to New York every year to give a talk at the main prostate cancer meeting. So I still have a lot of input into the US, and I still know a lot of people that work in the US. So I think the difference is that, you know, innovations are easy to bed in a private healthcare system such as the United States, because usually innovations cost money. And so in the NHS, for example, those things have to be proven to be cost effective before they're adopted. Whereas in the US, it's easier to adopt those things initially and then, you know, because people are paying for it, and then figure out, you know, whether it works well or not, you know, without having to have definitive proof before you could even start innovating. And that's why, for example, robotic surgery was first started in the US back in 2000. And I think the first robotic prostatectomy in the UK was 2007 or something like that. It didn't really kick off till 2010 or so. So, you know, there's almost a kind of 5 to 10 year gap. And therefore all the new innovations. So for example, now the standard robot has got multiple arms in the UK, whereas in the US now they've launched a single port robot where everything goes through one access point and then fans out like a Cobra, to have, you know, multiple arms but with one entry point. And that single port robotics has had FDA approval for, I think, now a couple of years. It's been around in the States, but still doesn't have a CE marking and hasn't yet been launched in the UK. Perhaps it will in the next year or two. So that there's always a lag, I think, between you know, technological advancements between the US and the UK, and that's partly to do with the public healthcare system in the UK compared to the private healthcare system in the US. So I think that's one major difference. Of course, the downside of US medicine is that although you can have all this technological advancements, things, you have to pay for it. So from a patient perspective, if you can't afford it, you get worse care. Whereas, of course, in the UK, you don't get such huge disparities between the best and the worst care, but perhaps you get more of a kind of level playing field for everybody. Mm-hmm. So the US has far more of those extremes, I think.
So, just talking now about the talk surgery masterclasses, you're going to be sharing your expertise. Before I ask you to tell me something about the content of your talk surgery and masterclass, do you do any streaming of your operations? How do you share your knowledge at the present time with medical students?
Yes, I mean, so from a medical student perspective, I'm a University College London UCL med school tutor or mentor. So I get to speak to medical students from that way. And of course, medical students, when they rotate through urology and surgical specialties, they will come and see us in theatres and stuff. But in terms of postgraduates, we get international fellows that come and visit us from all over the world. Sometimes they spend a few weeks, but sometimes they spend up to 2 years with us, and we train them, and then they go back to their home countries and bring the skills of robotic surgery back to their home country. So we have fellowship programs for them. And in terms of the wider community of, say, other consultant surgeons, I'm regularly invited to give sort of talks at meetings which used to be physical, but now are predominantly online in the new COVID-19 era. In fact, I've got one with the Urological Society in India this Sunday. So there'll be, you know, hopefully a few hundred Indian urologists that will log in and they'll listen to my talk on tips and tricks of a specific kind of robotic surgical rectus sparing surgery. So you can share things much easier these days because the robot allows you to record things. So you can have a big screen, you can record it. It's much easier, therefore, to disseminate training and tips with people. So, but a lot of it is as we're doing here. A lot of it is through Zoom. A lot of it is through YouTube videos and other video platforms, putting things on, presentations. So rather than live streaming, although you can do live streaming, the issue with live streaming is there are a few medical legal issues potentially with it. And I'm not a big fan of live streaming, because one of the problems with live streaming is your focus is divided between the patient in front of you and all of the people that will be watching it. And I don't think that's fair to the patient. I would much rather focus on the patient. I think every patient who has cancer deserves 100% of your attention. So while you do the operation, you can do that, focus on them, but then you have that operation recorded. You can then edit it. You can then, share it later. That's the beauty of it. What's the need to have to share it while you're doing it? I don't personally think that is fair on the patient. I also don't think it's a better learning experience. I think it's much better if the surgeon is focused on the patient, and then later on will edit their videos or show their videos and then be able to narrate it, because they're able to watch it and narrate it at the same time later on, rather than while they're in the midst of the operation.
Yeah, that's a very good point. And I don't have that much experience of prostate cancer surgery, but I did come across a guy who was a co-speaker at an international conference, an Australian, who'd had robotic surgery on his prostate cancer, and he was singing the praises of the precision of the surgery, which helped him to avoid some of the most common side effects of prostate cancer surgery. So coming now to your talk surgery masterclass in October, can in the next couple of minutes you tell us a little bit about exactly what delegates can expect from your talk surgery masterclass?
Yeah, I think initially we will start with a masterclass that's a couple of hours long, and that will focus on prostate cancer and robotic surgery in general. So I think delegates will be able to be fully versed in the advanced diagnostic techniques that we now have available to diagnose prostate cancer, because it's much more than it used to be, which was just a transrectal ultrasound scan biopsy. As I say, 10, 15, 20 years ago, we now have much more precision biopsy techniques with MRI as well, before biopsy, with fusion biopsies, where the MRI images can be superimposed onto the ultrasound images before biopsy. So we'll have advanced diagnostic techniques, how prostate cancer presents at different stages, localized, locally advanced, metastatic, and then the most advanced state-of-the-art treatments for the prostate cancer at those different stages, whether that's robotic surgery and different types of robotic surgery and different techniques of robotic surgery, like I alluded to, rectus-sparing surgery, which I am one of a few UK practitioners in, or advanced radiotherapy techniques, or advances in novel medications in terms of systemic agents for more advanced prostate cancer. So I think by the end of that masterclass, surgeons, urologists, oncologists, oncology nurse specialists, medical students even, or GPs with an interest in prostate cancer will understand exactly the full breadth of prostate cancer, have a nice overview, understand the benefits of robotic technology, which you alluded to in terms of increased precision, and how that importantly translates into patient outcomes. Because there's no point in having something that looks better, that feels better, that's easier for the surgeon, unless it improves outcomes for patients. Because at the end of the day, that's what it's all about. It's not about making my life easier or having a fancy gadget for the sake of it. It's about whether that translates into tangible benefits for patients, and how we can continue to improve benefits for patients to make the surgery, less morbid and more effective. And that really is what we're trying to do in this talk masterclass, so that patients, doctors, specialists, whoever it is, understands how to manage prostate cancer, how to diagnose it, how to manage it, and what are the different options for management, and why one option might be better for certain patients than another option.
Well, that should be a very compelling session. I'm captivated already, so I'm looking forward to being your host for that masterclass. And I just want to thank you, Mr. PS, for being with me this afternoon and sharing a little bit about your career and your expertise, and obviously your clear passion for what you do and sharing that knowledge with other people. So thank you very much.
Thank you so much, David. It's a real privilege and honor to be invited to your masterclasses. Thank you.